to everyone to the next Samvaad-Talk in the series of Medical AI. So we have with us Dr. Rajikha Raja, who is joining us from the University of Arkansas for Medical Sciences. And her talk title is Quantifying Human Brain White Matter Microstructural Organization using Tract-Weighted Imaging. Today's session is going to be chaired by Professor Madhav Rao from IIIT-Bangalore. He is an associate professor at IIIT-Bangalore. He also wears the hats of the IM Tech coordinator and the faculty in charge of labs. But what is more remarkable is the extensive research that he does in the VLSI and the robotics areas. So he works on approximate computing VLSI circuit design and hardware efficient AI designs. He is a recipient of several awards, including the Vishwesvaraya Young Faculty Fellowship Award. And he leads the HITES and the SARL labs at IIIT-Bangalore. So before I give the stage to Madhav, I would request all of you to stay tuned till the end of the talk and ask your questions at the end of it. We'll be happy to take the questions. So off to you, Madhav. Thank you.
Yeah, thank you, Jaya. Thanks for the nice introduction. But I think I'm here to introduce Dr. Rajikha. Dr. Rajikha, very glad welcome to you. Dr. Rajikha, I'm just going to read out your introduction. She's a postdoctoral researcher in the brain imaging lab at the University of Arkansas for Medical Sciences, and she's involved in pediatric brain development analysis. Previously, she has worked at the Mind Research Network, Albuquerque, and at the Georgia State University, Atlanta, where she did brain imaging research studies using the diffusion MRI techniques to understand about dementia and psychiatric disorders. She holds a PhD from IIIT-Bangalore, India. I think she worked with Professor Neelam. Her doctoral research investigated reconstruction and analysis of diffusion MR and DC MR images. So prior to joining the research, she had several years of industrial experience working majorly in imaging and medical domains. Her research interest centers around neuroimaging with a focus on developing new techniques for analyzing multimodal MR data and new diffusion MRI models specific to brain development and disorders. Welcome again, Dr. Rajikha, and over to you.
Thank you, sir. Thank you for the nice introduction. Good evening, everyone. It feels great to get connected with IIIT after a while. So for today's talk, I would like to share about two of my recent research studies related to diffusion MRI analysis. So to start with, I would like to start with introducing some of the basic concepts of diffusion MRI and tract-weighted imaging. Following that, I will get into the details about the studies that I'm going to present for today's talk. So neuroimaging and a role of MRI. So neuroimaging, when you study the brain using any modality of the image from any source, it's called neuroimaging. Let's say here the object is human brain and it's acted upon by any function. Here it's the scanner, and then you get a matrix of numbers or images or volumes, and then you do your data analytics on it to derive an estimate of your object of interest based upon the kind of the data analysis that you do. So this is what is generally done in neuroimaging research. Now, going to MRI. MRI is one of the modalities of medical imaging, and this comes with the luxury of having different contrast mechanisms, each one having its own specific applications related to different anatomy and different diseases. So in MRI, first we have the structural MRI, which deals with the volumetric measurements. Volumetric measurements, say, for gray matter and white matter. And then we have the functional MRI. So functional MRI is basically used to identify the functional connectivity. When you say the functional connectivity, it defines the similarity in neural activity between the brain regions. That's called as functional connectivity. And finally, coming to the modality diffusion MRI. So diffusion MRI reflects the movement of water molecules inside the brain tissue. Since the movement of the water molecules is very much restricted based upon the various structures available inside the brain, this indirectly gives you an idea about the structural information of the brain, and it helps to characterize these structures and the microstructural organization of the brain. That's the use of diffusion MRI. So moving on to the complex architecture of human brain. Human brain has various complex microstructures. And this one is the surface anatomy. So you see the complex, the morphology, the outside morphology, which contains a lot of folding, basically has the ridges and grooves that we call as the gyri and the sulci. Then inside the brain, you have the gray matter and the white matter. The gray matter and the white matter. Now, getting into the white matter, that's the topic of interest for today's talk. So this white matter contains axons, myelin, and dendrites. So axons relay the information between the neurons. And these axons may be covered with myelin, or it can be also without myelin coverage. These are the dendrites. And then these axonal fibers can be grouped into bundles, and they define the brain connections between the regions. These fiber bundles are called as tracts, and we categorize these tracts like commissural tracts, association tracts, and projection tracts, which is basically based on the kind of the regions it is connected to, and each of these groups is very specifically correlated to specific cognitive domains. And if one has to understand these deep structures, either you have to invasively study using the histological studies, or you can also study it non-invasively using MRI. That's where diffusion MRI helps. Now, coming to the diffusion MRI. So diffusion MRI quantifies the movement of the water molecules, and indirectly it allows you to study the microstructural information of the brain. And the movement of the water molecules can be isotropic when you don't have any restrictions. And this can be modeled as an ellipsoid, which is having equal magnitude in all the directions. The diffusivity of equal magnitude in all the directions. And then you can also have isotropic diffusion in a restricted environment. Finally, you also have an isotropic, very restricted diffusion. This happens when you have complex microstructures like myelin and axons, which doesn't allow your water molecules to freely move, and it's very much restricted due to the axons. This indirectly gives you an idea about the shape and the size of the fiber bundles. Now, when you have a raw diffusion MRI data, how do you go about from this raw data to getting brain connections at the end? So basically, this talks about the various the processing steps involved, which is what we call as the processing pipeline in diffusion MRI. It starts with pre-processing. So normally, when you have the images acquired from the scanner, it contains a lot of artifacts, which is due to the distortions, various kind of distortions like the motion distortions, eddy current, and then noise. So all these are corrected, a means of denoising or any artifact correction algorithms, and finally you get the pre-processed image. So then what you do is the reconstruction. In diffusion MRI, reconstruction means fitting the data, the pre-processed data, to derive the diffusion coefficients. There's been a lot of models developed for this. Each model has its own assumptions and it could be like analytical or numerical based methods. And then when you have the fitted diffusion coefficients, we derive certain parameters. So we don't normally use the raw diffusion coefficients because it cannot be clinically correlated. So in order to clinically correlate some information from this diffusion, we derive certain parameters using this diffusion coefficients, and these parameters directly relate to some kind of biological information about the human brain tissues. And then, so these three steps are very much common in all of the studies till getting the parameter maps. And after getting the parameter maps, you can also work on tractography to delineate the white matter tracts, and then finally do quantitative analysis based on the hypothesis of your study. So this is how we explore the brain connections using diffusion MRI. Now, coming to the reconstruction models. In today's talk, I'm going to detail about two of the studies which involve majorly two different models, DTI. One is DTI and one is spherical deconvolution model. So I thought I would give a quick glance about these models before starting that. So first is DTI model. So DTI model assumes a Gaussian distribution for the displacement of the water molecules. As you see here, the signal equation follows an exponential decay and it has a B value. So this B value is based on the acquisition protocol settings. Basically, it relies on the gradient strengths and the duration. The D is the diffusion tensor. So this is a tensor model. So from the tensor, you get the tensor is formed by the diffusion coefficients. And from this tensor, you can decompose to get the directions and magnitudes of the diffusion. So basically a eigenvalue decomposition. So which gives you eigenvalues and eigendirections. These eigenvalues lambda 1, lambda 2 and 3 talks about the magnitude of the diffusion, whereas the vectors talks about the direction of diffusion. In a simple case, when you have all these eigenvalues or the magnitudes equal, then it tells you that the structure is more isotropic in nature. That means the water is freely moving, and so you don't have very complex structures there. So it could be mostly either the case of a CSF, that is cerebrospinal fluid, or it can be a gray matter, where you don't have much complex microstructures. In case of an anisotropic diffusion, it tells you that the structure is a white matter. Then, coming to the parametric maps. So once you fit a model, you derive certain parametric maps. This is done in order to correlate it with the structural information of the brain. That's our ultimate goal. So when you have this diffusion tensor, so you can derive various parameters. For example, when you have a DTI model, in DTI model, these are the 4 parameters that we are normally interested in. The axial diffusivity tells you the magnitude of the diffusion along the fiber direction, whereas radial diffusivity gives you the magnitude of the diffusion across the fibers. Fibers means the axons. And then mean diffusivity gives you the overall diffusion in a voxel. Fractional anisotropy is a very critical parameter which tells you the degree of anisotropy in a voxel. Okay. So how do you clinically relate these parameters? Let's take different scenarios of the brain tissues and how do these parameters vary and relate in those scenarios. In case of an intact axon and a myelin sheath, you tend to have a very high degree of anisotropy because you have various microstructures in a normal brain. When these tissues are affected by any kind of pathology, first coming to the scenario of, in case if you have an injured axon, but still the myelin sheath is intact. In that case, you tend to have a very reduced axial diffusivity. Now, coming to the case of intact axon and injured myelin, what happens? You tend to have an increased radial diffusivity. And in the last scenario, when you have both injured, you have a very reduced AD and increased RD. is reduced in all these pathological scenarios. So this is how we connect or relate these diffusion parameters to the structural information of the brain. Okay. Now, just given a quick glimpse of one more model, that is the CST model. So constant spherical deconvolution model, I use this model in my tractographic applications. So this is an advanced model. This is being developed in order to overcome some of the limitations of the conventional DTI model. DTI model cannot handle multiple fibers inside a voxel, but which is the case, in normal human brain tissues. So in order to model that, the constraint spherical deconvolution model has been developed, which handles very much, multiple fiber populations inside a single voxel. For example, as we are seeing in the bottom row, we have delineated white matter tracts using, a DTI model and CST model. You can see in CST model, the fibers are very much, dense, and it actually replicates a real scenario. So this is the advantage of using CST model. Okay. Coming to tractography. So when you have the diffusion directions and magnitudes for every voxel, you can trace the orientation or the direction, and then you can trace a fiber pathway. This is called as tractography. So when you trace the fibers, you can either, you can get the connectivity information between two regions. What you can also do is you can group these fibers to form fiber bundles. So that is called as tracts. As we have seen, different kind of tracts, the categorization of tracts in the earlier slide. And then what you can also do is getting the trajectories. So these trajectories plays a major role, when you want to define a brain development, or when you want to define any kind of tissues, because in tissues, in pathology cases, what happens, these trajectories are very much, destructive. So these figures gives, depicts overall tractogram. This is a whole brain tractogram containing the full fibers, and it's shown in two different views, the sagittal and the axial view. Next. Coming to the tract specific analysis, which is the topic of today's studies. These tract specific analysis is a method for quantitatively analyzing the white matter microstructure. So when you try to get some quantitative information, which is very much tract specific rather than on a whole brain. This can be related to various scenarios, because when you say brain development happens very much differential in nature, which is very much tract specific. Not that all tracts tend to develop equally. So when you follow a tract specific analysis, you can very much use for these kind of applications. This is the whole brain tractograms, and you do a segmentation algorithm whereby you get the different tracts, standard white matter tracts segmented. So the challenges to address based on the steps that we have seen so far. So we have a lot of problem statements which are available right from acquisition to the statistical analysis. The one that I have been working on recently is related to these parametric maps and this tractography. So the parametric maps are related to generating novel contrast maps, which relates to specific biological information, and then tractography is for delineating the white matter tracts. Tract weighted imaging is one such tract specific analysis, which aims at developing novel contrast maps. So each of the map defines a different quantitative information, and which is very much tract specific. So I'm showing this 6 different kinds of TWI because I have been, I developed these different 6 contrast maps in my studies. For example, TDI is called tract density imaging. This information gives you the total number of fibers in any voxel. And APM is nothing but it gives you the average path length map. So it gives you the length of the fibers. So that's been averaged inside a voxel. So you take the number of fibers in a voxel, calculate the total number of lengths and average it out. So that is how different contrast maps are generated. Okay. Next, coming to the first study. So the first study is related to discriminating VCID subgroups. VCID is vascular cognitive impairment and dementia. So it has various subgroups, that is various classification of groups. And we try to discriminate this using a fusion approach. I start with explaining the project with which this work belongs to. So it's called MARC VCID. This is a multi-site consortium which is being funded by NIH. And the main aim of this is to identify different biomarkers from multiple modalities to distinguish the various VCID subgroups. Okay. The population that we used for this study contains three different categories, three different diagnostic categories. One is SIVD, and then AD and MX. SIVD is subcortical ischemic vascular disease. So this is the very prominent category, most prevalent one in the dementia. So this is a small vessel form of this VCID. It has a lot of white matter damage and it contains white matter lesions when you see in the images. And then Alzheimer's disease. This contains, based on the blood-based biomarkers, this contains a lot of amyloid beta plaques in the brain. And coming to mixed dementia, over aging, what happens when you see a lot of subjects, they have both these conditions, SIVD as well as AD, and they are categorized as mixed dementia. So we'll see how to distinguish between these three categories using diffusion MRI features. So I use a fusion approach in which I'll try to derive features from three different models. So the three different models are DTI, diffusion tensor imaging, diffusion kurtosis imaging, and constrained spherical deconvolution model. Each of this model gives you different parameters. So I selected 4 different parameters from DTI, then 3 different from DTI, and 2 parameters, that is TWI parameters, TDI and APM from CST. Then try to fuse all these features using a fusion framework and then getting the fused components to do a discrimination analysis. So these are like a representative maps for different, features that I have used. I have not included all the features here. This just shows 2 different maps from DTI, then 2 from DTI, and 2 from CST model. And this is how it looks differently for 2 different kind of, subject groups. One for the healthy controls, and this one is for SIVD. Going on to the next step. So this is generation of common mask. So in order to avoid any bias that's been introduced due to variations in the tract density between the subjects, we just derive a common mask that's been applied across the subjects. So we end up in using the same mask for a tract, which gives you the same amount of voxels to be included for all the subjects, so that it's helpful in the fusion framework, which expects your, the column and the rows number to follow same across all the subjects. So we generate this common mask by selecting first the voxels which are having more than 5 fibers. That's just to remove the outliers. And then combine all across the subjects, and finally select the voxels which contains more than 75% of the fiber density. That is how the final mask is generated. So these are the 9 different tracks that I used for this study. This is arcuate fasciculus, anterior thalamic radiation, cingulum, the corticospinal tract, inferior frontal occipital fasciculus, then inferior longitudinal fasciculus. This is optic radiation. This is superior longitudinal fasciculus, and then uncinate fasciculus. These tracks are selected based on the literature survey that we have done, and these tracks seem to play a very critical role for BCID. That's how these tracks are being selected for this study. Okay, next, coming to the fusion framework. So when you have all the features from the different models, what we do is, first, the fusion framework is based on a joint blind source separation model that involves 2 multivariate methods. So first one is the multi-set canonical correlation analysis that's been done for dimensionality reduction. And the second one is the ICA, independent component analysis, which gives you the independent components. Basically, it's trying to remove all the correlations, the redundancies, and getting you the independent components. Okay. So after getting the independent components, you do a statistical analysis. So in order to compare the method with the state-of-the-art method, what we did is we compared this multi-model approach with uni-model, where we use the features only from one model at a time. So we compared the results with both the models, and try to focus on the performance of the proposed method. It's also been followed by sensitivity analysis. Okay, this is just telling the overall steps. Like after generating the mask, then you extract the features and do a fusion framework, and get your mixing coefficients and the spatial components. That's the independent components. So ICA gives you 2 different kinds of output. One is the components, that is the spatial components, the maps, and along with that you also get the loading parameters, or it's also called as mixing coefficients. These mixing coefficients are statistically compared to find differences between different subject groups. Okay. So coming to the materials that we use for the study. So first, the participants. So the participants include like healthy controls, SIDD, mixed dementia, and Alzheimer's disease. And then the data acquisition involves a 3 Tesla MRI scanner with a very advanced diffusion acquisition protocol scheme, which involves both reverse phase encoding direction that helps for susceptibility distortion correction, as well as it involves multi-shell data with very higher B values that especially helps you to model using advanced models like constraint spherical deconvolution models. Coming to the results. So first, let's see the unimodal results. So then proceed to the results of the proposed method. First, the unimodal results. So here the mean values of the diffusion features is computed on the white matter tracks, and this is plotted here just for comparing your HC against SIDD, MX and AD, to identify the significant tracks. So you see the features here marked in the y-axis, and here you see the different. I have only plotted the tracks which is showing significant, not all the tracks. So for different cases, I have shown the different tracks which showed me the significant differences in statistical testing. So ATR, IFOP, ILF, SLF, and OR as shown here. So they show the differences between healthy controls and SLPD. And cingulum, UF, and CST showed between healthy control and mixed dementia. And then cingulum, UF, and AF showed between healthy controls versus AD. Okay. Now, after getting these statistical differences, I just plotted the p-values here, and each column represents a pair of the subject groups. So I have the different combinations, and then each row represents the white matter tract here, basically all the 9 white matter tracts that I used. And then this dotted line indicates the significant values. So the one thing to notice here is we don't see any of the feature here, discriminating between SIVD and MX. And we see very least in this category, like 1 or 2 features, not all, showing between SIVD and AD and MX and AD. So this is the disadvantage of unimodal approach. Now, coming to multimodal results. This shows the similar kind of plots that I showed for unimodal. So the p-values, and then you can see the difference in all these cases where we get very few results in unimodal. Here you can see most of the features showing a difference in case of SIVD and MX. Okay, so this is just a representative map of an output from diffusion framework. You get the spatial components which look like this, along with you get mixing coefficients, which is plotted here. This p-value shown here is uncorrected one, but it has a significant p-value after the correction for the different features and also for the different tracks. So this one is showed for a case of SLF and for a feature called FA. So you see the spatial components, it has values in different ranges, and you also have the mixing coefficients showing significant differences between SIVD and AD. This is how the output from the fusion framework looks. Okay. Now, seeing the output for the significant result. So here I have taken 3 different pairs, the important pairs for which unimodal didn't perform well. And I have plotted here 3 different, the least p-value categories, 3 least p-values for every pair, for 3 of the pairs. And you see how the spatial components and the mixing coefficients look. Okay, so from this kind of result, how do you interpret, the spatial components and the mixing coefficients? So this is basically based upon the magnitude, the sign of the values in the spatial components, also the sign of the values in the mixing coefficients. So for example, when you take these interpretations are summarized in this table. For example, when you take the case of SIVD versus MX, so you see the first independent component. So based upon the values of the spatial component and the mixing coefficients, we say that the ATR, so this is shown for ATR. ATR is the white matter tract, anterior thalamic radiation. The RD is very much increased in MX. That is the inference that we get from this. And then going on to the second IC, we see ATR MK is decreased in MX, that is mixed dementia. And for third one, the FA is decreasing SIVD. So this is how we interpret the results, and we see for these tracks are very much, significantly different from the normal and from the other disease categories. Okay. So since the sample size that's been dealt in each of the subject group is not very higher, it's lesser, we try to do a sensitivity analysis so that we can prove the reliability of the group differences that's been done earlier. So here we have done ROC curves. This has been done using logistic regression. And here we have compared between the unimodal and the multimodal. And finally, we see we prove the accuracy using the AUC, and we see the highest AUC for all of the cases in multimodal as compared to the unimodal. In case of SLF, the highest AUC is for predicting MX, and in case of ATR, the highest AUC is for predicting SIVD. And for CST, the highest AUC is for predicting AD. So we end up in getting or identifying the specific tracts which are very much different for a specific disease group. Coming to the conclusions, so the findings in this study highlight the improved sensitivity of the fusion approach. Usually this fusion approach is being previously used for fusing features from multiple modalities. So this is the first attempt, where we have tried the fusion on different features from different models of a single modality. And we also proved that it gives very much, significant results for identifying different, very difficult disease groups which has very much overlapping symptoms, and that couldn't be, discriminated by unimodal methods. Okay. So now quickly going to the next study. This is a tract-weighted imaging again. So here we worked on using this tract-weighted imaging for studying the brain development in healthy children. So to start with, what we have done is, this is a preliminary analysis, this work. So where we just try to find the sexual dimorphism and the hemispheric differences in children. Let me start with explaining first the project. So this is part of a project called Brain Power. So in this project, the main aim is to study the brain development, because we use data, the diffusion MRI data from children at various time points. So the main aim is to delineate brain development in terms of both structural information as well as finding the influencing factors by associating, the different factors like neuropsychological scores, sleep disorders, infant diets, and maternal and prenatal, postnatal, maternal variables to the white matter structural information. So coming to this particular preliminary analysis. So the main aim is to investigate the sex differences and also the hemispheric asymmetric patterns, which is called as lateralization, what we call the structural lateralization. So we use tract-weighted images. So this is a preliminary analysis. So what we aimed is, we just used one contrast from TWI for this particular study. So that is APM, which is average part length map. So it denotes the average length of the fibers which is passing through a box. And for this study, we used 37 well-known white matter tracts. Each of this tract is delineated first, and then the APM measures are derived, which is compared between boys and girls. And then the measures, the TWI measures, are compared between left and right hemisphere to get the lateralization. They provide additional data to understand the differences in the white matter microstructures at the tract level. And this is, this may have very important functional implications. The participants used are healthy children in the age range of 8 years, and they are very much healthy, full-term born and right-handed. So we used a very basic DTI protocol in this, which has a single B value and a 15 gradient directions. Initially, the usage of tract-weighted imaging is being very much discussed for using in such a basic acquisition protocol. Based upon a lot of experimental results and experiments, we proved that the tract-weighted imaging works on such kind of even basic data, and it has significant findings. Okay, again coming to the methods. So it's a similar kind of processing pipeline that I followed earlier. It starts with different models, and then you do a tractography and then try to find different TWI measures. So here I am showing all the different contrast maps that I have been used for this project. And for the study, I used APM contrast map. Then instead of using a fusion framework that I discussed in the previous study, here we just used a statistical analysis to find the sexual dimorphism, that is by using a general linear model involving various covariates like age, like the brain volume, and other socio-economic factors. And then coming to hemispheric differences, we had two hypotheses. One is the left greater than right, that is the left lateralization. And the second one is the right greater than left. Okay. Coming to the results. So first result is with the gender differences. So we could identify 11 different tracts which showed significant differences between boys and girls. For all this tract, the very important thing that we could see is, the very interesting thing is, in all the tracts, the APM measures were higher for boys as compared to the girls. So I have just plotted here the 11 different tracts that showed me significant differences. You can see starting from corpus callosum. Corpus callosum 3 is Corpus callosum 3 is the third segment of corpus callosum. And then we could also see for cingulum right. Then SLF 1, 2, 3 are the three segments of superior longitudinal fasciculus. So we got significant differences for SLF 1, left and right. So that's for bilateral tracts. And then again for MLF. So then for the other tracts. Okay, so now what's the interpretation from this? So why do you see, the differences between boys and girls? What it actually tells you about that? So the increased white matter development, which is associated with myelination, the fiber growth, and fiber density are the indications in boys. So for which we are getting these gender differences in terms of the APM. When we reviewed the literature survey, we could see, some of the studies which are even aligning with these findings. The major differences that we could show is, this is a very tract-specific analysis, which is very specific to 11 tracts, whereas the studies showed overall whole brain indications, and then they try to parcellate the whole brain, identifying specific regions, whereas this one is very tract specific, and we could readily pick up the tracts which be showing the differences. And then why all these boys having higher APM than girls? So when we reviewed the literature, in one of the studies where they used children from age range of 10 to 12, they even showed the same kind of finding, showing that boys have higher FA and lesser MD, which is very much correlated with the current findings. And they say that maybe the higher testosterone levels is related to these higher white matter integrity for boys. Next, coming to the hemispheric differences. Hemispheric differences is also called as asymmetric pattern, or the structural lateralization. So these results are very unique in the sense that we see some of the tracts showing the same kind of lateralization for both boys and girls, and then we have yet another set of tracts which showed only for boys and only for girls. Let's see all these cases now. Okay, so coming to left lateralization, we see the AF and OR, it showed, for both boys and girls. In both boys and girls, they have the left, white matter very much organized or very much developed as compared to the right hemisphere tracts. And ATR, the anterior thalamic radiation, showed left lateralization only in boys, not for the girls. Next, coming to right greater than left, that is right lateralized. So we see this for both boys and girls in all of these 5 different kind of tracts. IFOF, MLF, SLF, FPT is frontopontine tract, and then STR, superior thalamic deviation. And one thing in walls, we see this in right lateralized for different kind of tracts, I think. And then two of the tracts show a right lateralization for girls only, but not for boys. Okay, so what's the interpretation for these results? So the white matter asymmetry, they have observed lateralization in both boys and girls without sex interactions. This is what is done in literature survey. So they have no sex interactions, but they have shown this asymmetry. In our results, it's very much unique with that we show the the influences of each other. So normally, when we compare to the past studies, we could also relate the left lateralization to language-related tracts. So which could be one of the possible reasons for the lateralization. Yeah. So the conclusions, the sex differences showed higher APM values in walls especially, and then in coming to lateral asymmetries, we see similarities as well as differences. So we see similar kind of tracts showing similar lateralization in both boys and girls, and for some of the tracts, it's very much different. So this had potential implications in cognition and behavior. Thank you.
Thank you, Dr. Rajikha. Wonderful talk. Both the talks were wonderful. So we will take the questions now. If we have any in the chat first. I don't see questions. Maybe I think if anyone wants to, in the audience wants to ask any questions, feel free. Right. I have one question, Dr. Rajikha. I hope you are able to hear me.
Yes, yes.
Yeah. So regarding this characterizing the white matter, do you think in the future or or in your lab there is anyone who is trying to segment the white matter within the 3D reconstructed MRI imaging? Is that a possibility?
Yes, we very much do that. So
okay.
Usually, there are various different kind of parcellation atlas which is available for white matter. Normally ranging from 70 to 130 parcellated regions. So
okay.
Yeah, this is a region specific analysis which is being followed very much related to white matter.
I see. So I foresee that once we characterize or once we segment the white matter, I think there will be there will be a unique advantage, especially in dissecting or whatever the tumor removal purpose and all those things.
Yes. So as you said, the parcellations can be or region specific, or it can be also tract specific, because when it comes to white matter, tracts play a major role. Wonderful. Especially in tumors, in tumor, so dissection and all that.
Yeah. I had one more question, if time permits. Maybe being the chair, I will ask one more. What is that confidence of characterizing the white matter in the models you have developed? Did you statistically estimate the confidence with respect to the ground truth results, or is that a possibility?
Yeah. Yes, the ground truth basically. In terms of diffusion MRI or in terms of other MRI, we don't have ground truth. The ground truth that is being used is when we develop a model. So in that time, the ground truth used is the phantom or the simulated measurements. So using a phantom validation or a simulated measurement validation, that's how we develop models. So later on, when we develop models, we try to prove this with various real data. And another kind of validation is using histological data.
Okay.
These are the options as of now which is available for any model to prove that how it is reliable and how does it mimic the actual human brain.
Yeah, that makes sense.
So I have one question.
Sure, Neelam, go ahead.
Hi, Rajikha. So these differences you showed, this is pre-adolescence, right? So the age group is around 8. So
Yes,
do these differences hold when they are adolescent also? I mean, that kind of study would
yes.
substantiate?
These studies are actually age specific. You cannot generalize it for all the age groups. So that's why when we select the sample size, we make sure it's in a within a age group to generalize for that particular age group. Normally between 8 and adolescent, I don't think so. It varies very much. So what varies very much is when you do an infant, the brain, the white matter tracts looks entirely different because it has very less myelination and very much higher water content. So you don't see much tracts developed, either prenatal or postnatal. Then after then you see the developed tracts during adolescent and children. And when you again see the aged people, you have the deterioration. That answers your question?
Rajikha, this is Jaya. I have a question.
Yeah.
So nice talk. Thank you. And congratulations on all the great publications that you have now. So Rajikha, my question really is, so if the way you have mentioned this multi-model method, is this the same as a multimodal method? Like they are different modalities, that sort of thing?
It is similar in the sense that the framework, the separation model that we use is a little bit similar. It varies in the way that the features are being how the features are being fused. So in multi-modal, we use the features from different modality altogether. For example, say we use functional connectivity from fMRI and fused with structural connectivity from diffusion MRI, or the volumetric measurements from the structural MRI. So these being fused, and the components that we get has to be interpreted in a totally different way. So here we try to fuse the features from different models of the same modality.
Okay. So then the question is like, so is there anything specific characteristics of these models that you need to be
Yes,
conscious about to sort of integrate them, right?
So each model gives you specific information, and the kind of the processing also varies.
Okay. So what was your criteria for choosing DTI, DKI, and I forget the third model that you are using?
So as I mentioned, each of the models has been developed, based on a particular assumption, and also to avoid or to overcome the limitation of a earlier model. But still, when you take DTI, the information that you get from DTI, like anisotropic information, is not available in any other model. And when you go to DKI, you get a non-Gaussian distribution. So that is using the kurtosis term. So you get that particular information. So the feature tells you about that. And when you go to CST, you get something related to the fibers, the fiber density. So when you use these different information, so you get an integrated, approach.
Okay. So you're then doing some sort of like a late fusion, right? You find the features and then you're fusing them together. You're not fusing the data itself together, correct?
No, it is only fusing the features actually. Yeah.
Okay. Thank you, Rajikha. Yeah, I understood. Thank you so much.
Thank you.
Yeah, thank you, Dr. Rajikha. Yeah, thank you for your time.
Thank you, sir. Hope you all had a good time and some information from the talk. Yeah.
No, absolutely. It was very very consolidated information in both the talks, I would say.
Thank you so much, sir. Thank you.
Yeah.
Thanks, Rajikha.
Thanks, Rajikha. It's been great having you back. Yeah, so we'll end the Samvaad talk here. Thank you all. And we'll have the last talk in medical AI next week with Professor Neela. So thank you, everybody. Good night. Bye.